All right, let's dive right in. Today, we're tackling one of the toughest chronic diseases you'll see in the pharmacy, rheumatoid arthritis. We're going to build a practical guide covering the diagnosis, the key medications, and, most importantly, exactly what you need to say to your patients to keep them safe and on track.
Okay, you know the scene. A patient walks up to your counter looking a little overwhelmed and hands you their very first prescription for RA. This is a big moment. This isn't just another refill, it's the start of a whole new chapter in their life. And what you say in those next few minutes, well, it can make all the difference. This whole explainer is designed to arm you with the key points to absolutely nail that conversation. So before we jump into the drugs, let's quickly talk about the diagnosis. Because if you understand the why, it's so much easier to explain the what and the how of their treatment. This isn't just about chasing pain, it's about hitting the brakes on a disease that can cause some serious damage. Now, the key words on this slide are systemic and autoimmune. It's so important to help patients get this. RA is not the same as the wear and tear arthritis their grandma might have. Here, their own body's defense system is confused, and it's attacking their own joints. That's why starting treatment early and aggressively isn't just a suggestion. It's absolutely essential to stop that damage in its tracks. You might get a patient asking, how did my doctor even know I had this? Well, it's not just a guess. Rheumatologists use a kind of scorecard based on these 4 things. They look at which joints are affected, check for specific antibodies in the blood, measure inflammation markers, and see how long it's been going on. If the score is high enough, that confirms it. And this is why getting to a specialist fast is so important. The clock is seriously ticking.
All right, let's get into the medications. We're starting with the absolute foundation of RA therapy. Honestly, this is the drug you are going to see and counsel on more than any other for this disease.
For pretty much every new RA patient, the journey starts right here, with methotrexate or MTX. Barring any major reason not to use it, this is the gold standard. It's what we call a conventional synthetic DMARD, and it is the rock upon which all other RA treatment is built.
Okay, listen up, because if you take away one thing, it's this slide. These counseling points are non-negotiable. First, and you need to shout this from the rooftops, it is taken once a week. Not once a day. Put a sticker on the bottle, highlight the directions, whatever it takes. This is a life or death counseling point. Second, folic acid. It's not optional, it's mandatory. At least 5 milligrams a week, and here's the key. Taken on a different day than the methotrexate. This is huge for cutting down side effects. You also have to prep them for things like nausea, mouth sores, and just feeling wiped out. Reassure them that regular blood tests are part of the deal to keep them safe. And finally, have that chat about alcohol. They really need to cut back to protect their liver.
So, what if your patient isn't on methotrexate? Chances are you'll see one of these. For sulfasalazine, the big word is sun. It can make people really sensitive to sunlight, so you've got to counsel on sunscreen and protective clothing. For hydroxychloroquine, the word is eyes. They absolutely must get a baseline eye exam and regular checkups. It's a rare side effect, but retinal toxicity is serious, so we don't mess around.
Okay, but what happens when the first-line drugs just aren't cutting it? Well, that's when we have to level up. It's time to bring in the big guns, the advanced DMARDs. This quote right here, this is the whole philosophy of modern RA care. We call it treat to target. We don't just wait and see what happens. If a patient isn't getting dramatically better within a few months, the rheumatologist is going to make a change. So if your patient comes in saying their doctor is already changing their medicine, this is why. They're being proactive. I know this looks like an alphabet soup of drug classes, but we can make it simple. You've basically got 2 main buckets, the biologics, or BDMARDs. Think of these as highly specific missiles that target inflammatory proteins outside the cell. Then you have the targeted synthetic DMARDs, or TSDMARDs. These are small molecule pills that work inside the cell to shut down the inflammation signals from within.
Now, here's some really good news. Even though there are tons of these advanced drugs, the critical safety counseling is pretty much the same for all of them. Think of this as your universal cheat sheet. The number one point is the risk of infection. Patients have to know that any fever, any persistent cough, they need to call their doctor right away. They also have to be screened for TB and hepatitis before they even start. And, a huge one for us in the pharmacy, no live vaccines. This is a massive safety check you help enforce.
Treating RA isn't just about the joints. We have to zoom out and look at the whole person. The constant inflammation running through their body puts them at a much higher risk for other serious health problems, and we can help manage that.
Here is a fact that should change the way you think about RA. A patient with rheumatoid arthritis has a risk of having a heart attack or stroke that's comparable to someone with type 2 diabetes. Let that sink in for a second. This is so powerful because it means that when we help them control their RA, we're not just saving their joints, we are literally helping to save their heart.
So, given everything we've talked about, a haywire immune system plus medications that suppress it, vaccines become incredibly important. But which ones are safe and which ones are dangerous? This is a question you will get, and as a pharmacist, you're in a perfect spot to be the expert. And thankfully, the guidance is super clear. The rule of thumb is this: inactivated or dead vaccines are good to go. So the annual flu shot, the pneumococcal vaccines, and the new shingles vaccine, Shingrix, we should be recommending these to all of our RA patients. The absolute hard stop, the one big rule, is to avoid all live vaccines for anyone on those advanced biologic or targeted therapies. All right, let's keep going on our safety theme and tackle a really important topic: patients who are thinking about starting a family. The conversations we have here are absolutely critical.
This slide is your go-to safety reference. The two drugs with giant red flags are methotrexate and leflunomide. They are absolutely contraindicated. And for methotrexate, get this, it has to be stopped at least 3 months before trying to conceive, and that goes for both men and women. On the flip side, there is some good news. Several other medications like hydroxychloroquine and even one of the TNF inhibitors, certolizumab, are generally considered okay to use during pregnancy, but always under a specialist's close watch.
So, where does that leave us? Well, our job doesn't stop after we counsel on that first fill. In fact, that's just the very beginning. For these patients, you are one of the most consistent and accessible healthcare providers they have. Think about all the hats you wear. You are the safety expert on these high-risk drugs. You are the adherence coach, reminding them why it's so important to stick with it. You're the public health advocate, making sure they're up to date on vaccines and aware of their heart risk. But more than anything, you're the person they can trust, the one who empowers them with the knowledge they need to take control of their disease. So the next time that patient walks up to your counter with that first RA script, you'll be ready. You have the tools now to go way beyond just dispensing a medication. You can offer the counseling that keeps them safe, the encouragement that keeps them going, and the knowledge that helps them not just live with RA, but actually live well. So the only question is, how will you make that difference?